faculty, and he has more than 35 publications to his credit. Apart from this, he has a good extracurricular activity. He is a stand-up comedian. It's a rare combination of doctor being a stand-up comedian, and he's well known as a stand-up comedian. He conducts some shows of stand-up comedies, and his inputs we expect a lot of inputs from him because we are going to present some of the surgical complication cases in the second part of this program. And welcome, Dr. Muruganandam. And joining him, two speakers going to present. One is Dr. Vel Aravind. This forum doesn't need any introduction to him. He's very popular among all the nephrologists, and myself, along with him, both we started this program, the peculiar case series renal transplant 3.5 years ago. And he has been not only a nephrologist, he has a unique character of being a nephrosurgeon, actually. The only and one and only nephrosurgeon in India, probably, I don't know, and perhaps in the world, actually. He does a lot of, he's very much interested in transplant and particularly anastomosis and complications. Any complications, surgical complications you think of and you would have encountered in his practice. And many times he became a savior of any surgical complication when we call him at any time, and he used to advise what to do next and all. And this presentation is going to be very interesting because these are the things which we nephrologists are in the gray area. We depend upon the surgeons to follow the outcome and all. And if we know about some of these complications and if we are aware of these complications, I think this could be a better, this could have a turning tip in the management of patients in transplant. And we're looking forward to see his presentation. And joining him is Dr. Nayan, and who is a resident from Nizam's Institute of Medical Sciences. And he's going to present his first his case. He'll be ably guided. He will be guided by Dr. Sribhushan Raju. And without wasting much of your time, I invite Dr. Nayan to start his presentation.
Good evening, sir. Thank you for giving me this opportunity to present here. I would like to thank Rajarajan sir and Velarvin sir for giving me this opportunity, and my mentor, Dr. Sribhushan Raju sir, for giving me this opportunity to present here. I would like to start my presentation. My the case the basically is the beyond the usual aspect, a rare cause of transaminitis in renal transplant. We'll see a case. We'll see a case. First, we'll go through the case details. The 29-year-old male who was diagnosed as chronic kidney disease in 2017. At presentation, his hemoglobin was 6.2, serum creat was 10.7. Renal analysis showed a 4+14 with nil active sediments and 2 to 4 per cells. USG is suggestive of both the small kidneys and native kidneys was presumed as chronic interstitial nephritis. And he was initiated on dialysis through right IJV non-tunnel catheter, which was followed by left radiocephalic AV fistula. Dialysis frequency 3 times in a week. He had 2 units PRBC synthesization history during his 6 years of dialysis vintage. During his course of dialysis history, he received IV iron supplementation 100 mg every 3 to 4 months, which were around cumulative dose of 2000 mg. This is a table showing the pre-dialysis and the pre-transplant values of the hemoglobin, liver function test, and the iron profiles. As we see in this table, the patient started receiving iron supplementation. So his ferritin level started to increase. When he was started on dialysis in 2017, his ferritin level increased to around 1100 in 2021 and around 2900 pre-transplant. This was around in February 2023. But his liver functions were normal at this time. He underwent disease donor renal transplant in April 2023. He received induction with recombinant ATG at 3 mg per kg, which was followed by maintenance with triple immunosuppressants. Patient had immediate graft function and was discharged on post-op day with serum creat of 0.8. He was started on prophylaxis with tablet valganciclovir and cotrimoxazole. Further, we see in the post-transplant history that the serum is was able to maintain graft functions, good graft function. But as we see that this table on post-op day 45, his liver functions, there is SGOT, AST and ALT levels started to increase. And at this level, its tag dose were around 2.5 to 2 mg. And its tag level was 6.46. Before initiating, it's before at this level, its tag dose was 2.5, 2.5. We did a regular reduction at 2.5 to 2 mg on post-op date 45. And as we see this table, its liver functions were started to increase from post-op day 45, and it maintained, it started to increase and never normalized beyond that. So for that, we stopped tablet valganciclovir on post-op day 50. And if after stopping also tablet valganciclovir, his liver functions were not normalized. So post that we stopped tablet cotrimoxazole. This is a table which further shows that patients had deranged liver functions in increased AST ALT, but his serum creatinine graph functions was maintaining. Its total bilirubin, direct bilirubin levels were maintained. The TAC level was slightly increased at around 9.01 at a dose of 4.5 mg. So at this, TAC reduction was done. And other etiologies were ruled out, like viral workers were done, like hepatitis workers were done, and which came out to be negative. And his USG abdomen was also done, which was history of fatty liver disease. So, according to this, we'll see the differential causes of first, what are the causes of the transaminitis in a post-renal transplant. These are the most common causes of the post-transplant transaminitis. First, the most common is the drug toxicity, common with tacrolimus, MMS, valsartan. It improves with reducing the dose. Second common is the viral hepatitis, which can be due to CMV, EBV, HBV, or HCV. And the third one is a metabolic liver disease. In this patient, we see that all the three were came after removing, after decreasing the dose of tacrolimus and stopping Valsact. Also, its liver functions were not improved, and all the viral hepatitis markers were negative. And his USG was not suggestive of any metabolic liver disease. So we went forward to see other causes of the transaminitis. And during at that time, the patient started having skin darkening, and erythrocytosis with persistent transaminitis. At that time, his hemoglobin was 7.2 with a red cell count around 5.7 into 10 to the power 6, and ferritin levels were around 1700. So this pointed to us to look for the causes of other causes of transaminitis. And when we and for this we did the MRI abdomen to rule out hemochromatosis. So MRI abdomen was suggestive of this is the image of the MRI abdomen, which this A is a T1 weighted image and B is a T2 weighted image. A shows hypointensity in the liver at segment 5 and 6, and B shows the hypointensity in the liver with in the liver. And this C and D shows the ROI value. ROI value is around 128, which roughly amounts to liver iron concentration of 6 grams, 6 milligrams per gram. Sorry. And so for the diagnosis, for the tissue diagnosis, we went forward with the liver biopsy. The liver biopsy was suggestive of pulse stain positive, which was indicative of hemosiderin deposits, and which came out to be hemochromatosis with the nodule formation. Nodules were seen in the liver biopsy specimen. This is the HP specimen, suggestive of the pulse stain positive, indicating hemosiderin deposits. And then went forward with the genetic test, which was sorry, which was suggestive revealed a heterozygous mutation for H63D. which confirms the patient's susceptibility to hemochromatosis. Basically, when the patient is homozygous mutant, the hemochromatosis could be there. But when when it is heterozygous, means one copy is mutant, one copy is wild type, hemochromatosis could be there. But it predisposes when there is immunosuppressive medications or surgery that can predispose heterozygous manifestation mutation. So we went forward with the treatment of the patient, and this was the first. This is a table which showed which is showing the phlebotomy at the level of what phlebotomy was done. We did four phlebotomies of the patient. First, before phlebotomy, his hemoglobin was around 17.9. His ferritin was around 1700, and AST and ALT levels were increased. Well, after doing regular phlebotomies, its hemoglobin came out to be it decreased to 14, and ferritin level also decreased to 235, and his AST and ALT levels also normalized. This is the flow trends showing the decrease in the ALT and ferritin and hemoglobin level after phlebotomy. The arrow shows the phlebotomy at what level was done. So management is regular therapeutic phlebotomies. After four phlebotomies, we saw that his ferritin levels declined to less than 300, and hemoglobin came out to be around 14, and aminotransferase levels also decreased. So now we will see what is the approach to transaminitis in post-renal transplant patients. So this is a flow chart showing the approach to transaminitis. If when a patient presents with elevated hepatic enzymes in early post-transplant, first is the drug toxicity. We should common culprits are the ganciclovir, which are started as a prophylaxis for the patient, cotrimoxazole, and the CNIs. So first thing we have to do is the dose reduction or drug discontinuation. If there is no improvement after the drug discontinuation and reduction, then we should evaluate for other causes of the non-drug etiologies, like infectious viral causes like CMV, hepatitis B, or hepatitis C. If it is all these things came out to negative, then we have to see the other non-infectious causes that can be secondary to dyslipidemia, obesity, diabetes. It can be due to alcoholic hepatitis also. In this case, we ruled out everything, and then we went forward with the evaluation of other causes. Why hemochromatosis is missed in post-transplant cases? Because it presents with non-specific symptoms. Symptoms mostly overlap with the drug side effects or metabolic syndrome. We are more focused on anemia management and not iron volume. And in our workup, we mainly emphasize on viral hepatitis and drug-induced liver injury. For what are the clinical cues we have to see in case of when to suspect hemochromatosis post-transplant? When the patient has persistent unexplained transaminitis and the ferritin levels is more than 1000, transferrin saturation is more than 45, and there is no clear infectious or metabolic cause. And what are the diagnostic workup we should do for that iron panel should be done, in which we have to see mostly the ferritin and transferrin saturation. Second is liver imaging. Then we have to go forward with liver biopsy, and if possible, if the genetic testing of the patient. What is the management? If management, if phlebotomy is feasible, or if phlebotomy is not feasible, then we have to go with the chelation therapy, and we have to monitor liver enzymes, iron study, and liver stiffness for fibrosis progression. What are the key takeaways from this case? That hemochromatosis is a rare but important in post-transplant transplantation. We have to consider this cause also when there is persistent LFT elevation, liver function test elevation, and there is high ferritin and transferrin saturation. Then an early detection of hemochromatosis can prevent cirrhosis and optimize transplant outcomes. Thank you, everyone.
Raj?
Thank you, Dr. Nayan.
Thank you,
It's
sir.
a short and a sweet presentation. Some important points have been discussed, and which we don't see actually, which we don't suspect hemochromatosis for a simple elevation of transaminitis. Dr. Sribhushan sir, your comments, please.
So good evening, everyone. Hope I am able to. Am I audible?
Yeah,
Yes.
yeah,
Yes,
yes.
sir. Yes, sir.
Yeah, thank you all for
Yes, sir. Yes, sir. Carry on, sir.
So thank you all for giving this opportunity of presentation. In fact, we don't suspect hemochromatosis in each and every case. This boy, though the resident told that he has been looking very dark and a dark complexion and all. Even before that, also he was giving a dark complexion, and there's a change in his body morphology, also especially the face and the skin. And but he has been on dialysis since a long time, and most of our patients they look very dark. And moreover, due to this particular government program of dialysis, which is the free of cost, and also some of the protocols have been set in routinely where they will be getting once in 3 to 4 weeks or once a month or twice a month IV iron therapy, irrespective of whether they have an iron deficiency or not. Irrespective of iron deficiency, they'll be given routinely several grams of iron, which usually I tell them not to take, and I insist that they should go for an iron profile. Then only they should be given, if at all they are found to be having iron deficiency. So here, though he has accumulatively, he has got a huge amount of iron, which we calculated after that, taking the book of dialysis. And meanwhile, when we stop, most of the times our patient will be having a TAC-related toxicity-related transaminitis, and which improves with a gradual decrease in that. And meanwhile, we stop the statin, if at all that is there. We stop ganciclovir and cotrimoxazole also. And we will be watching them. Here, the boy is not improving over a period of time, irrespective of whether, despite having a decrease in the TAC levels and all. Then we suspected that by looking at the change in the morphology and all, we thought we should look at the hemochromatosis, such a kind of a thing. And we went ahead with MRI as a screening modality. And luckily, the MRI helped us in giving a clue. Then we went ahead with the liver biopsy. The liver biopsy confirmed it. And then we wanted to see what kind of a genetic tendency he has got, because we give a IV iron, almost every dialysis patients across the world will be receiving routinely. And okay, he received through 2000 or something like that, but many patients would be receiving several grams of IV iron if at all they were to be on 6 to 10 years of dialysis program. So how come he developed such a kind of a extensive deposition of iron along with the nodule formation? So that's why we checked genetic tendency, and he has got some genetic tendency for that. So what I feel is that, so indiscriminate use of IV iron during dialysis should be prevented, should be curtailed actually. We should not really allow the people to give IV iron without confirmation of iron deficiency. That's first one. And the transaminitis post-transplant, not just viral, not just drug, but there are several other varieties which we are supposed to think of. And luckily, these phenomena are very rare, but still we require to have an idea about what's happening to the liver after the transplantation with so many drugs. And you cannot really blame one drug also. Simultaneously, you'll be stopping so many drugs. Like you can at once you can stop cotrimoxazole, ganciclovir, statin, and all. But you don't know which drug really is the culprit. And meanwhile, you start decreasing the tacrolimus also at the same time. So in that way, you'll never know whether which drug is truly the one culprit and which caused the transaminitis. So in this way, once you ruled out all the things, despite having a change in the drug therapy, if you have a transaminitis still persisting, then probably you can think of these rare diseases, which we thought probably is appropriate for us to share with all of you.
Nayan, please stop sharing so that we can see the speakers. Okay.
Sir, thanks. Sorry, sir.
Yeah. Okay, sir.
And we'll be very happy to take up any questions related to or any clarifications required in our approach or the protocol, or probably we can see any different kind of a protocol or any different differential diagnosis related to this particular case.
There, sir. Nobody will suspect. Raj? Rajarajan?
Am I audible?
Yeah, yeah.
Sorry. Yeah, sorry.
You went out
Thank-
of Yeah, okay.
PL.
Raj, now you're going on and off.
Am I audible? No, sir, sorry.
It comes interrupted, Raj. You're going away from this. Your voice comes back again.
Probably some network issue. Sir,
Okay.
Steve Bhushan, sir, thank you for sharing this importance of evaluating a transaminitis post-transplant. And what are the other causes of
PL type the question clearly.
Hello.
Yeah, hello.
Yeah, sir. So what are the other causes of elevated ferritin, which we need to know about that in this?
See, ferritin is an important molecule which routinely has gotten a elevation whenever there's an acute inflammation. But here the patient has got no other acute inflammatory markers. But post-transplant, it is very short period. So he must be having some kind of a chronic inflammation, which we routinely think. But here the interesting thing is that not only the huge amount of ferritin, but also the transferrin saturation, other parameters, the serum iron, and all others are significantly elevated. It is just one of the parameters where you can suspect that. It's not just the one. But whenever such a clinical scenario comes, we just ask for an MRI, which is a very important marker. In fact, we try to ask the nuclear medicine people whether iron load in the organs can be detected through any nuclear scintigraphy. But we could not get any support from them. Then we thought MRI would be a better option. And we asked for an MRI of the liver, which can really detect the quantity or of the iron deposition within the liver. So that's how we could get a clue out of that. We suspected basically because of so many clinical criteria, clinical discussions, rather than simply saying that it could be immediately in a hemochromatosis. It turned out to be something very interesting later. But after that and before that also, we had several cases of transaminitis. Most common cause of transaminitis in our group of people, if I say 100, probably 60% of them would be tacrolimus related. Around 20% would be ganciclovir related. Another 10% would be cotrimoxazole related, and a small percentage would be statin related. You know that we don't give a statin for each and everybody immediately after the transplant, but as a protocol, we give a statin for some of the patients at risk for coronary artery disease and some of the clinical situation whenever it warrants us to provide a statin therapy to them. So rest of all the patients would be. So most common cause is a tacrolimus only. Probably over a period of time, if you totally decrease the TAC, it would have actually come down. What I feel is that it is a genetic susceptibility in this patient for the hemochromatosis compounded by the addition of the drugs like tacrolimus and all other drugs is the one which culminated ultimately in expressing his condition as a transaminitis. So I feel that whenever such a case comes, we should suspect the rarest of the rare conditions, which can really masquerade as a simple and innocuous conditions.
What is the role of desferoxamine? You do only
We thought
phlebotomy
of,
for these cases. Is there
yes,
any role of desferoxamine?
we thought of deferriprone, deferoxamine, deferriprone tablet also. We thought of, which I gave very long back, almost 28, 30 years back during my MD residency. I gave a lot of desferoxamine as an MDM student also. For one of the patient, I gave almost probably 100 days. I must have given a desferoxamine after every session of dialysis for one of the patient. He received almost 120, 150 blood transfusions in Delhi after failed first transplant. But deferriprone also we have given those days in 97, 98 when it has just came into the market to decrease the iron as an important chelation therapy. But only thing is that these drugs are toxic otherwise and very difficult and tedious process to give it to them. And post-transplant, we don't want to take any kind of a risk which can really trouble us as far as the immunosuppression things are concerned. And no study, no case report, no literature support will be there for us to say that these drugs are safe in post-transplant. And as such, our patients are very fragile and labile to any kind of an unnecessary drug therapy. So better not to give, and just let us see a simple protocol which is absolutely harmless in the form of a therapeutic phlebotomy. So then we went ahead with the therapeutic phlebotomy and we started monitoring him carefully. And probably we need to see, I'm worried about the nodule formation which has been seen in the histopathology. And over a period of time, whether he truly gets into the cirrhosis at least 3 to 5 years or 10 years after the transplantation because of the particular thing, I am more concerned about it rather than anything else. So, in fact, that's very important for us to monitor their liver functions over a period of time where he can get into a chronic liver disease, ultimately culminating in cirrhosis of liver.
Thank you, sir. So before closing this session, how do you monitor, how do you follow this patient, sir?
We have been checking the hemoglobin as well as the liver function test regularly once in 2 months. There's a gradual decline and almost normalization of the liver function test now. And hemoglobin also got stabilized at around 14 grams per deciliter. and he received a good amount of therapeutic phlebotomies, around 5 to 7, and we told him that always see that his hemoglobin is around 14. In order to maintain it around 14, he can go for as many as therapeutic phlebotomies in the next few months, probably once in a month or something like that. We advised him in such a way that he can come regularly, check the hemoglobin, iron profile, and go for therapeutic phlebotomy in the next few months. So we need to go for an elastography or once in 3 months to see whether there's any change in the liver structure and ecotexture ultrasonogram wise. So elastogram, we have done it. We did not see any major problem
Right.
with that, but we'll be monitoring once in 4 to 6 months to see whether it will ultimately lands up in cirrhosis of liver.
So one question from chat box that why liver enzymes elevated when he is actually not on iron treatment in post-transplant period?
That's what
So,
I stated
yeah.
actually. I did get this answer actually, a question
Yeah, you
properly.
have answered the question that it's the disease process started. That's why he is.
Basically, the genetic susceptibility are compounded by the addition of these drugs, which are hepatotoxic otherwise. Individually, they may not be significant enough to produce hepatotoxicity, but together, with an underlying genetic susceptibility, could ultimately culminate in manifesting hemochromatosis with him.
Thank you, sir. Thank you for the wonderful explanation and a wonderful case, actually. And thank you, Dr. Nayan, for your neat and sweet presentation.
I also feel,
And,
Thank you, sir.
sorry, actually, I also feel that it is a cumulative amount of iron which probably is still there with him. We did not do any major exercise in removing the iron also from his liver. So he received a huge amount of iron, and along with the particular drug therapy, where we failed to remove that. So he gave an opportunity for us to see that the liver will come down in the form of elevated liver enzymes, only to see that the excess amount of iron which is deposited in his liver is being depleted of slowly through therapeutic phlebotomy. Probably it will postpone the occurrence of cirrhosis of liver over a period of time. Probably if it were to be developing in 5 to 6 years, probably it might get postponed to 10 to 12 years after transplant.
thank you, sir. Thank you very much. Thank you.
Thank you all. Thank you.
Thank you, sir.
Dr.
Thank
Vaid,
you.
you can start your presentation.
Thanks, Raj. Raj?
Yeah, sir. It's visible.
Visible. Okay. Fine.
Yeah.
Thanks, Raj, for the very friendly introduction, and we enjoy each other's comradeship ever since we started practice here. Today, it's a very there are a lot of cases. I took a four interesting case. I'll be presenting some of this theoretical with some practical aspects. One case is mine, and I've taken 3 cases from other institutions, from our friends, and all cases were de-identified, and so identity will not be shown here. So, what's happening?
Slides not moving, sir.
Yeah, okay, sorry. The first case, a 32 years old male, this is my case, and it's a 32 years old male with end-stage kidney disease, received a kidney transplant from his mother a year ago. The kidney retrieval involved laparoscopic nephrectomy, during which the kidney was completely degloved. The problem was, even surgeon was doing laparoscopic surgery, and the gas system was little malfunctioning, so he could not get the adequate CO2 inside the abdomen. So with the compromised situation, he was operating. And finally, at one stage, he thought, well, let's remove the kidney. That's what happened. This mishap happened. So the initially patient showed good output. The transplant was good, and later it was observed that half of the urine was draining through a catheter, Foley's catheter, and the other half through a drain. It's called weeping phenomenon, because when the capsule is not there, the kidney surface start producing urine like via naturalis. I mean, ureted into the bladder into the via naturalis. The drain exhibited typical urine characteristics with a lower concentration compared to normal urine. This is what described in the textbook, little hypoosmolar. Despite efforts, the drain could not be removed, and patient continued to produce urine through the urethra and drain. Eventually, drain was removed and a peritoneal window was created to facilitate the drain into the peritoneal cavity. However, due to renal scarring, patient developed uremia and had to resume dialysis by 1 year. It's a very sad story. So, degloved kidney. What is a degloved kidney? It refers to stripping of the renal capsule during retrieval, leading to exposure to renal parenchyma. It could be excessive traction, or dissection tearing of the thin renal capsule or iatrogenic injury during kidney extraction from the retrieval port. So this injury can have serious consequences on graft viability and post-transfer function. This is the first message we should have in our mind. It's not a simple thing that degloved kidney will work forever. This was a case. We show some of the pitch snapshots as well as the video. A totally degloved kidney. So we attempted keeping the kidney in the ice slush. We spent almost 20 minutes to, put around, wrap around the whatever the torn and the renal capsule, but we could not do anything. So this was another thing, and he had some aberrant polar artery also. So this was showing to you, and here this was the kidney, and so we anastomosed. So just internal iliac artery, one branch we anastomosed external iliac artery, and so I just kept keeping some warm saline before it, and I think one slide was exchanged. It was totally degloved kidney. So we are about to take out the venous clamp first. So one venous clamp down, and I'll go some of the slides fast and some of the slides slowly, so that it's a venous clamp, and subsequently we are going to remove the arterial clamp. Once arterial clamp was removed and a lot of surface ooze was there, and we were just sucking out around the kidney. Almost we lost around 200 to 300 ml of blood, and we didn't do. See, that time it was new to me. It was the first case had like such a degloved kidney, and then whatever we had in mind was that we took multiple collagen and we put around the graft, and ultimately what we would have done later, I realized that we should have opened the peritoneum and took out the omentum and wrap around it. That should have been the better choice. So the whole kidney was well perfused. Patient was, graft was making good urine output. So this was the final view. Then we used a collagen to wrap around the entire kidney. Somehow it was not described in the textbook. That's what we could do that time, and we could not leave the entire degloved kidney open because we'll be touching the external muscles and other things. It will produce a very quick fibrotic reaction. That was we were expecting, and so what are the physiological? I just want to remove something obstructing my. Okay.
Yeah.
Something central bar is obstructing my view. Okay, what are the physiological functional structure and in a capsule? It works. It acts as a barrier. It's a protective cover. Acts as a barrier against external trauma, infections, inflammatory cells. Maintains kidney structural integrity. Prevent another third function is very important. Prevent excessive expansion during changes in blood volume and pressure. So, and pressure regulation, restrict the swelling and helps maintain the intrarenal pressure during homeostasis. Prevent excessive renal parenchymal distension, protecting against ischemic injury. So the all pressure regulation. Vascular function, it facilitates the venous drainage. That's what is the very important function which plays a role in post-transplant degloved kidney. Renal capsule contains small lymphatic and venous channels which aid in venous return if the disrupted graft may develop venous congestion leading to edema and impaired perfusion. And it also has a capsule has got a lymphatic connection. This lymphatic vessel that drain interstitial fluid, preventing fluid buildup and edema formation in the renal cortex. So the loss of the capsule can impair lymphatic drainage, exacerbating the congestion of the renal transplant. So what is the role of renal capsule in transplant? It maintains structural integrity, thereby prevents excessive graft expansion post-transplant, reducing venous congestion. Intact capsule prevents hematoma formation. It helps contain minor bleeding and protect against post-operative hemorrhage. So it's very obvious that once you have don't have any capsule, what are the issues will happen? It is the immediate issues. The bleeding from the exposed parenchyma. It's a very difficult hemostasis, and it can create potential graft injury. And some of the blood will collect around the moment you close and you leave it, and the post-operative period, much of the blood which collect around the kidney will produce a perioperative hematoma around the graft. It can produce a page kidney. In the long run, the inflammatory reaction can go for fibrosis. Venous congestion can produce a delayed graft function. As a matter of fact, this patient never had a normal function. Though he was making around urine 5 liters, 6 liters, the creatinine never came down below 2.5. Then the weeping phenomenon. This is the one thing we were really worried. And patient was making as much as urine via naturally is in the drain also. So he was making 1 liter in the Foley's catheter and 2 liters in the drain. So consistently was showing some high elevated urea and creatinine with the solutes, half the solutes of like sodium, potassium of that of urine. So typically this was weeping phenomenon surface because the whole kidney was exuding urine from the surface. So now we know that preserving capsule is crucial for optimizing transplant outcome. What are the late complications can happen? It produces as happened in our case, it's a parenchymal fibrosis, produces nephron loss, chronic hypertension due to page kidney, and because the hematoma can become organized and can produce a page kidney, and high risk of renal scarring and chronic allograft nephropathy. So the capsule loss will produce scarring, chronic fibrosis, and reduced long-term survival. So what are the management can be done? Intraoperative strategies, access the extent of degloving, assess the right. If it's less than 10%, 15% capsule lost, conservative management, try to repair the capsule here and there, put some stitches around it, and cover the entire graft with whatever the capsule is left over. But if it's more than 50% loss, intervention is required to prevent venous congestion. What intervention still we don't know. Probably omentum can be brought when peritoneum can open, omentum can be brought in near the graft and can be wound around the entire graft so that it can give some kind of protection. Hemostasis, bleeding control, like surgical, but I think most of the people I encountered, few anecdotal evidence my friends are sharing with me. Once a degloved kidney like this would never survive beyond 1 year. This is a point to be. So we have to we have to be very, very vigilant while extracting the doing nephrectomy. Meticulously, we have to take care of the capsule, especially during lap nephrectomy, upper pole. Sometimes inaccessible. Surgeons may leave some of the ligamental attachment, without cauterizing it and releasing. So sometimes when blindly we put a hand and pull it, this deglove can happen in any situation. So this can be avoided. So we have to time and again inculcate this fact into our whole team. So deglove is not something we can expect in our patients. Second case is a parenchymal laceration. 32-year-old male. This case borrowed from another institution. A 32-year-old male is scheduled to receive a kidney donation from his 54-year-old uncle with a right nephrectomy chosen as a procedure. The surgical team opted for laparoscopic right nephrectomy, which was progressing smoothly until a significant complication arose near the end of the surgery. The renal vein met with some issue, prompting the surgeon to swiftly remove the organ through a subcostal incision on the right side. During the retrieval, right kidney was unintentionally lacerated by the protruding 11th and 12th ribs. So here you can see some of the one area here and another is laceration here. The entire kidney, the other surface is normal. So fortunate that it is only some kind of laceration is not entirely dividing the kidney, but I think the force utilized must be very gross because you can see the multiple lacerations at a different level. So it was a real concern for the nephrology team who was watching all this thing. And so next, what happened? So what are the types of renal trauma during organ retrieval can happen? The trauma to the kidney can occur at different stages during donor surgery, perfusion. Perfusion also can produce sometimes, here and there we'll just try to pull the very flimsy, very thin vessels. It may damage storage and the transport also. Sometimes storage, the eyes directly contact the eyes into the renal capsule, renal hilum. And the other, the destination point where the surgeon try to pull it with force, it can detach the capsule or vessel can torn apart. So these are the things can happen. So what are the things can happen during retrieval? The vascular trauma, arterial injury, venous injury, multiple arteries may be damaged during retrieval. Arterial stenosis can happen. Sometimes intermittently, sometimes place clamp. This excessive handling, all these things can produce arterial thrombosis. This, I think during nephrectomy, lap nephrectomy or open nephrectomy, arterial stenosis due to stretching, trauma, is something really unwanted things. And this will produce definitely some result, I mean, very bad result in the recipient surgery, immediate post-operative period. So that is a parenchymal trauma, cortical laceration, capsular tears, subcapsular hematoma, and contusion. Contusion is very common. We often see contusion here and there. Sometimes subcapsular hematoma, and it will be patchy. You put a leaven knife and make a small nick, and that will get relieved. But large capsular tears, we will not worried if it is not severe enough to entirely, invert and expose the entire graft. And cortical laceration like this is a little concern. So ureteral trauma can be there, ureteral avulsion, and a thermal injury can be. Sometimes we can during lap while dividing the gonadal vessels, and sometimes heat damage can cause thermal injury. Ischemic injury, if inadvertently you just strip out the entire tissue around the ureter, this can also happen. This all happen during retrieval. So use the kidney if minor vascular injury can be repaired. Capsular cortical laceration are not extensive. Discard if kidney if a major vascular injury that cannot be repaired, especially renal artery thrombosis, and extensive parenchymal damage leading to poor perfusion. But severe ureteral damage, it's a surgeon choice. Some center they may go into native ureter. So it's a plus or minus. It depends on the expertise of that particular team. One can manage the situation well. So what happened? They did a very nice job. They took a gel foam and they put it in the cleavage of the laceration. They took a nice sutures over the gel foam with just encircling the lacerated point over the gel foam through a renal capsule. So they filled nicely. That's what happened. See, after the anastomosis, then there was not much bleeding, it seems. They were anastomosed external to external, and they observed for a few, 20-30 minutes, there was no bleeding at all. So this is the point I learned from this case. Gel foam can be applied like this, and meticulously they did a stitch over the capsule. This is a gel foam and upgel. There are two things. I'll just go into some of the differences. They use a gel foam because of porcine derivative. And so this is what a difference between. The important thing is mechanism of gel foam and upgel. Function-wise, the gel foam is better because it controls bleeding by absorbing blood and promoting clot formation, whereas the upgel can stabilize after the clot is formed. Whereas the gel foam promote and stabilizes. So this is the cardinal difference. And the general surgery, generally gel foam is preferred than other things. So it's some kind of comparison. You don't want to go through it, but gel foam is preferred to upgel. So this what this video was sent by one of our colleague. A patient was discharged with 1.2 creatinine, and pole to pole, the perfusion was good, and the spectral pattern was adequate, and the till cortex, the perfusion was adequate. So, routinely we do see such kind of in patients, routinely see here and there when the retractor during the fourth port, some retract and all, they'll just inadvertently poke the kidney here and there, some small kind of this we routinely see in most of the nephrectomy specimen. So if it is so deep, then we are very aggrieved about this kind of activity happening again and again. So see almost three areas there is some kind of laceration, but nothing happened after releasing the clamp. So this we have to time and again tell our surgeons to be very careful. It's not surgeon, the people who are assisting the surgeon might get overlooked, and they'll pull pressures might produce all kind of things. This one. The third case, so graft artery thrombosis. This is a very exciting case recently we had the last Saturday, that is 28th of February. This is a ADPKD patient. Already left nephrectomy was done. The other kidney we plan to do on table. So that's what we planned. This so it was space. Definitely the space was it was obstructing the space to be created for the incoming kidney. So it was well planned. So it was removed very easily, but it was weighing about 3.6 kilos. So this is what. So this is the patient. I'm not able to read it properly, but anyhow, this is the case. First two lines, it is obstructing my view. Okay, this is a patient. He received a kidney from his sister. Final cross match was negative. The left kidney donor was harvested through the laparoscopic technique. The warm ischemic time was approximately 8 minutes. The moment the clips were applied and artery and vein were cut, there was some attachment from the hilum to the aortic area. The surgeons just want to cauterize everything before taking out the kidney. So it took almost 4 minutes extra. So clamped ice time was only 8 minutes 35 seconds. bench perfusion was uneventful. Kidney showed a good diuresis back table, and artery and vein were single. Renal artery anastomosis, the external iliac artery. His immediate graft function was excellent with an urine output of approximately 600 to 700 ml per hour for nearly 36 hours. So, and at approximately 37th hour, that's next day, 9 p.m., there was an abrupt decrease in urine output from 300 ml to 75 ml per hour, followed immediately to a complete anuria. There was no pain at the site of graft, no gross hematuria. There were no signs of urinary tract obstruction as per the USG assessment. Doppler done immediately showed an abrupt cutoff of blood flow through the renal artery near the anastomotic confluence. He was immediately shifted to operation theatre, and the re-exploration was effected with no further delay. So easier said than done. So it was almost all surgeons were 45 kilometers away. It is a Saturday evening. You can imagine the situation in institution. So this was a message I received from one of the resident, 11 p.m. So he just posted a message. He didn't call me. So I just, when the flash was on my phone, I just opened and I saw that it's a video of a transplant. Absolutely, there's no flow. Though he was novice, he was not well versed in ultrasound technique. The moment I saw the video, something happened because anuria and no flow. What else could be there? Because sister was the donor. I don't think any immunological problem. So this patient actually experienced a gradual decrease in urine output noted in the logbook from 300 to 150, then 75 ml between 7 and 9 o'clock. By 10 o'clock, it had reduced to 20 ml, but the staff did not raise any alarms. This is point to be noted. Any assigned staff should tell. See, people tend to look 1 hour to hour, like 9 to 10. So that 9 to 10 o'clock in between, what is the flow of the urine? People are not bothered. This is what we have to teach our staff inside the post-transplant room. So we do great amount of work pre-transplant, on table, getting legal permission. Just 1 hour of that lapse in their attitude, indifferent behavior, lack of professionalism, all will lead to a catastrophe in our patient's life. So this she's not bothered. She raised in alarms. Luckily, a urology resident, he was conducted. He just took up very cursory routine rounds. So he started learning the Doppler. He just put a Doppler and he shared the findings via video call around 11:10. Upon receiving the update, I just realized that you have to prepare for theatre to be ready. So everything went in a very one after another. He activated. He first called the anesthesia team, arranged all requirements for an urgent intervention. So the time elapsed between anuria to exploration 3 hours and 15 minutes. It's a Saturday night. Just imagine. So, and everyone was in a hurry. And when we opened, it was an external iliac anastomosis, and the artery was in vein was in situ, and the ureter was this is a new kind of approach. And see, whenever you see we clearly see only the arterial problem. So what we opened, we applied a clamp over the vein across the external iliac vein. Then we applied one more clamp over the external iliac artery, both one satin clamp. Then we disconnected the graft artery from the anastomosis. Then one could see, this is not clear, but I just zoomed into the other picture. It was a granular texture, very fibrin-like material, fragmentable, and it was coming from, like, when you prick a vein in a peripheral vein after 3-4 days, if you go and open and for AV fistula, you'll see some kind of granule material, such kind of things. It's not a red thrombus, it's a white thrombus-like things. So when we saw those things, then we took a video, but some of the granule material video was missing because I don't know who took the video, we don't know. So I could only retrieve this kind of information from available sources. So there was a friable material. It was extending till the hilum. We ejected it out and we made sure that everything was clear. Then we put so just a point. So when you see early arterial thrombus in a kidney transplant patients with the granular and fibrin rich. See, this is very important. It's not a renal vein thrombosis. It's a arterial thrombosis. It's a fibrin rich. Then a typical blood clot to the following reason. This is the pathophysiological mechanism. Surgical trauma, ischemia, reperfusion, injury can produce, because artery is a high flow system. So where you can only see platelet adhesions and fibrin deposits, which can produce only granular-like material. What else will come to our mind as a nephrologist? Arterial thrombus can happen in ABMR or TMA, complement coagulation interplay. But unlike in venous clot, which forms due to stasis and coagulation, where you will see the red thrombus, a rubber-like material will start from the origin, will go until once you remove the clot, the entire clot will come in toto because it's like a rubber-like material. Here, it's all fragmented. You have to go up, milk it out from the hilum. So that's what we did. So one I muted, one I just put in a one. I just explain what happened. Everything was topsy-turvy, everything very running here and there. Like, so here what we did, we disconnected the artery, we keep the vein in situ, we made a nick in the vein, and we started perfusing the graft through the whatever the remaining artery was available, and we let out the whatever the perfusion goes into the graft will come out through the hole we made in the renal vein. So this is what we did. This is to save time and see the late night, 12 o'clock, 1 o'clock, midnight, and we're exhausted on a Saturday night. So if you take out the kidney in toto and keep it in back table for complete work, and re-anastomosing will be some kind of time-consuming, laborious work. So that's what we did, and we did it many times in such situations. So graft, see, I wanted to show some of the moment we went inside, the texture of the graft and the color. It's not like, the moment in the first sight of the graft, it gave a lot of confidence that this graft would work. So unlike, it's like a dusky black, very, very, very soft graft. This graft was little, it was maintaining the integrity shape, and it was little, white, and here and there, some pink patches were there. So we thought this could be. The another important point we learned from this case, when we made a nick in the renal vein, the gush of blood was coming, there is no clot. So my theory is, if a patient in the past, I just anecdotal experience, when you get a case like this, if you have a even clot in the vein, this kidney would have gone to a trash bin. This renal vein was intact, graft vein was intact. When we made a nick, the gush of blood was coming through it, no clot at all in the vein. So probably some kind of a venous pressure maintaining the backflow into the graft. In a dying tissue will extract oxygen. It's not in a you need not produce oxygen. Tissue will extract oxygen from the whatever the venous side of the graft. So this gave some kind of a confidence. This graft can be salvageable. So we perfused with 1 liter of cold saline oral with diltiazem added into it, and so this is what this we did. This is soon after the clamp release, 5 minutes, and this is after 15 minutes. The funniest thing is the happiest moment was the graft started producing urine, and we did a Doppler. Doppler was showing Nandi pattern. It was like a typical systolic diastolic flow. So this is what this happened. So this all some of the everyone took videos from their mobile, whichever, because we want to document everything, at least for the legal purpose, for the academic purpose too. That's what our intention was going in our mind. So this is so what are the common causes of graft artery thrombosis? Surgical and technical factors. I'm not going to detail because I think I'll just 10 minutes I'll finish. Surgical and technical factor, kinking, torsion, compression. See, the surgeon will know. Sometimes you know the excess length, everything. See, moment of post-operative complication comes, the surgeon will feel that, oh, this is what the problem should have happened. So this is a very close discussion between team will come to a quick conclusion whether it is a surgical or immunological one. And hypercoagulable state, I don't want to go into detail. This completion sake of written. Sometimes hemodynamic instability, prolonged hypotension, immunological factor, vascular abnormalities like a pre-existing atherosclerosis donor artery. We had one patient like that, and infection like DIC and cyclosporin tackle, because we have a tendency to start cyclosporin prior to transplant. And excessive use of vasopressor also can promote this kind of atherogenicity and thrombus. So this completion sake. So what are the clinical features? Any sudden onset of oliguria, sudden, like if patient develops 10 o'clock good urine, 10 he develops anuria, then only 2 things can happen. One is the complete arterial occlusion or very hyperacute rejection. 2 things. So looking back into the history, I think you can conclude which is that's why we should keep one ultrasound, good ultrasound machine always ready inside the transplant room. and all the assigned staff should be able to do at least two things. Just switch on the ultrasound, put a probe, see there is color flow inside. If they do this thing, this will save many grafts in our life. So, and there is no graft tenderness here. I mean, this is all the presentation. Absence of Doppler flow is a cardinal sign which will give you the next management of, so diagnosis, ultrasound management, as we said, anastomosis, other things. So I'm not going into detail about this. This already alluded to. So just a kind of repetition sake, and why it is a red thrombus, why it's a white thrombus. And see, many times nephrology will think that only antibody rejection, severe ischemia, hyperacute, but there is surgical trauma also we have to think in gut. So it's a potentially salvageable. So I just need 2 minutes to, this is an important piece of information I got recently from one of the cardiovascular surgeon. They use this micropore pencil probe. If anybody wants, I'll provide information. I just recently bought is a piece of information about this. And see, any graft, suppose you do 3 or 4 grafts for anastomosis, especially this patient, if you, after anastomosis, we want to see like a pencil probe I have here, and I'll show you at the discussion. I'll show you. I have it right out with my hand. You just like a pencil probe. You just put across anastomosis. You will get a different pattern of arterial. More than this thing, it's not a very 1 minute talk. It needs a minimum 15 minutes of explanation. I'll just rush through, but just keep in mind this graft really works well. I mean, this probe, this will avoid all unnecessary nephrectomy, unnecessary tension inside the OT. So cardiovascular people are using soon after grafting. CABG grafting, they put this probe and see PI, pulsatile index. Anything pulsatile index more than 5, that graft will not work. That CABG graft will not work. So they are using routinely in all patients. So this as well can be utilized in our purpose. So this is what we used in some of our patients. So intraoperative confirmation can be very well done with this my pencil probe. So this is what the probe is, a very small probe. We used for some other patients. We had 2 anastomosis when we were very doubtful about the anastomosis. More than the graph, you have to see the noise. The audio will give a lot of idea. Even venous flow can give arterial flow before anastomosis, because anastomosis near the high level, all will give. This is a probe, right? So case number 4. And anybody wants detail about it, you can go and see. This is called BIDOP 7. It's from Japanese meter. This can, I think, any high flow volume center, if they're doing very complicated gas like 3 arteries, 4 arteries, this device is a must inside the OT. Okay, this is the 4th case. I'll just finish by 5 minutes. And 32 years old male is a cadaver transplant. Everything went well. Is because it's a donor was a 26-year-old female, cause of death spontaneous ICH, hypertension. The recipient was 32-year-old. Cold ischemia was 2 hours 52 minutes. So here, after clamp release, patient, this graft was showing uniform swelling around the graft. So what could be your next line of thinking? So here was here the distant view and very close view. So it was like a tense. This is what the surgeon's perception, the finger perception should give a lot of idea about what is what. So, and the situation, right? Where the kidney is harvested from, what is the donor status, all things, all put into one piece and try to analyze very quickly, because moment, if you don't do anything very aggressive, either patient will go into DIC or unnecessarily remove the graft. So either way it can happen. So based on the appearance, my view, based on this appearance, it appears to be a large subcapsular hematoma. The mix of dusky islands and white patches may indicate a vascular rejection. See, any vascular rejection, kidney will be turgid quickly or it will be soft. But in a cadaver transplant, what definitely we see a lot of TMA rather than a vascular rejection. You get a here and there patchy with a very tense kidney. But here, given the overall uniformity of this color and global enlargement, one may tend to make an assessment of hematoma likely. So what should have been done here? My perception. Keeping the kidney in situ, call for a Doppler. See the micropencil Doppler, you had one, then put across both artery and vein. The both will give a signal about intrarenal flow. Then put a bigger curvilinear probe over the graft and see whether this kidney receives blood or not. If it is so, open the capsule, try to remove the hematoma, then analyze again. If the wave pattern improves, that it's a subcapsular hematoma. This is the best way to confirm the diagnosis of this. But unfortunately, surgeons was very apprehensive about the patient disease and thing. He did a quick nephrectomy, and once you made a very cautious opening, just carefully watch. There is a he has removed the capsule. You say try to see inside. There is, I think, to my eyes, it looks very normal kidney. There is no patchy kidney like this, but it's not. This is a view we can get it from our friend. But since the high level of anonymity is maintained here, we don't want to disclose any kind of thing. So it's what a very okay. So when you suspect a subcapsular hematoma after capsulectomy, what are the things you can possible cause? See if you see after capsulectomy, if you see a pink color, it is confirmed subcapsular hematoma. Then evacuation, observe for refilling, cleaning. If remain dusky and swollen, it's a venous thrombosis. If it pale, arterial thrombosis. If mottled and island of patchy discoloration, is ischemia, rejection. I think this is the best chart one should have in mind before doing any kind of aggressive or a knee-jerk reaction kind of things. So one can have this, and first thing is you have to confirm the diagnosis. The most important thing is intraoperative Doppler and group discussion. What to next? Then control capsulotomy. Then successful decompression should improve. Then give perfusion to the system, improve the volume of the patient. Then try to finalize Doppler flow, hemostasis control. Then post-operatively watch closely. This is what the thing should happen. So unfortunately, it was removed. So post-operative monitor renal function, serial Doppler. Do see if you keep one ultrasound inside the theater, inside the post-operative, ask your staff do every hourly ultrasound. It is ultrasound monitoring of a graft. That is the best way we can decentralize our responsibility to our younger staff, assigned staff, then keep our system very viable and our stress-free life we can lead. So in essence, the last point, in essence, any post-operative room should have a designated, very high quality designated ultrasound machine. It's worth investing a good ultrasound machine in a post-transplant room. All assigned staff should be proficient in basic ultrasound techniques as 2D, color, and spectral imaging. It is important to remember that hospitals conducting regular random transplant should have a specialized emergency protocol in place. Having this contingency plan, like keeping one different surgical theater ready, and all the time when a transplant is there, always give a call that one of the senior nurse should come there immediately to help to bail it out of all difficult situation. So this would give us a complete sense of responsibility as a transplant team, so that we can justify our work in the long run. Thank you, Raj. Thanks for giving this opportunity. Thanks.
Thank you, sir. Thank you for the eye-opening and fantastic presentation of 4 different cases. And as we always see, medical complication, we have a knowledge how to manage that. Certain protocols are there. These kind of complications which occur, and it is like an instinct that has to be acted on the time. Actually, many times we falter. The last case you presented, we had a similar scenario when I was doing my residency in Stanley. The same thing happened. We did a nephrectomy, and we did an incision, found a lot of gush of blood is coming out of this capsule, and the graft was found. It was a pinkish graft, actually. So these are all the and the capsular avulsion of capsule. I haven't seen such kind of issues, and I wonder how come a full capsule has been degloved with when you retrieve it. Actually, it is so without compromising vascular airway structures, and it's very intriguing. Another one thing, if you have a laceration, how long it will take for the kidney to seal? Actually, so you're keeping a gel foam, right? And will it interfere with the sealing of the laceration? Is it safe to keep?
Right question asked. I think Muruganathan is there. He will be able to tell better. But I searched the net and I found a very reasonable answer. If it is 1 centimeter depth, it will heal very quickly. If it is more beyond 1 centimeter through till the cortex reaching the medulla, then it's a problem. That's a problem. Then you will compromise so many things. I think the depth of this laceration looks like 4 millimeter, 3 millimeters. I think that's why it will. So it all depends. We don't know really. We don't know really what it is. We have to observe. If it is a multiple laceration, the problem. So here there are 3 laceration. One laceration may heal very quickly. Itself in the polar region, laceration may not give much problem. Muruganathan, please, you can rescue me.
Yeah. Muruganandam, this is the reason why we called you. Actually, you was one of the eminent transplant surgeon, and you could give some of your inputs regarding this complication. You might have encountered this kind of complications.
Yes, left.
Muruganandam, you are muted.
Yeah.
Please unmute yourself.
Right.
Yeah.
Yeah, now it's okay.
Yeah.
Thank you. Yeah. Actually, yeah, thanks for the invitation, everyone. I think for a minute I was lost. I could not differentiate whether I was in a hardcore urology conference or a nephrology meeting. I was lost. So such a wonderful collection of cases. And congratulations, Dr. Vail Arvind. Again, he has got the mind of a physician and a heart of a brave heart of the surgeon, I think. He is able to talk to the depth. So to be actually frank with you, I have got nothing much to add. Both the practical and also theoretical aspect is very well covered. So two cases I will give my comment. Number one is that the complete capsular, it's like a complete deglowing. It's quite rare. So as you rightly pointed out, Rajarajan, this can happen at it's a less than 50% also can happen few times when it is a good volume center. But this complete this thing is rare. There are two options. The injury to the capsule occurs during the dissection, during the retrieval, and when we after declamping, if there is a small subcapsular hematoma, the plane is so good actually. It is just like the banana peeling. It's that plane is so well already. So there's a little bit pressure, it can dissect the entire kidney. That what is the last case what Dr. Vela has shown. To have developed a hematoma, it is nicely developed all around. They could not differentiate between it's a blue graft or a pink. So these are the things. I think it was unfortunate that we have lost that graft. Probably what would have happened is the capsule could have been retrieved. And I see the problem sometimes can be the fat can be thickly adherent to the capsule. We call as a toxic fat.
Yeah.
The fat can be just, it can easily come, sometimes it can, sometimes it can infiltrate in multiple places. When you want to remove the fat, it is nicely the capsule also comes. So at that point also, probably the capsule could have been nicely dissected all around, retrieve as much as capsule as possible, at least make 3 or 5 wrapping around the kidney, the upper pole 2 wrapping, lower pole 2 wrappings. The mid pole is difficult because of the vessels. Little bit around, just put this thing all around and allow the peritoneum to fall over the kidney. Then if needed to few stitches. And another thing is the patient is not so, especially if the patient is having little bit of ascites is good. You decompress ascites, a good amount of peritoneum can be retrieved. It can act as a capsule. So this would have prevented the urine leakage outside. And I won't think it's a good idea to do a peritoneal window for a urinary collection. It is not a good idea. Anyway, you lost that graph. That's this. So it's a very first time I'm seeing such a completely it's a Nanga kidney. You know, it's become Nanga. Okay, so that's very unfortunate. This and I don't think the difference between lap and open. It's just not the tool. It's a surgeon technique. It can happen in both open and lap. And it's another thing is next is the this rib poking into the kidney. Probably they would have had the other desperate situation. You need to act in time. They've retrieved this thing, and he told nicely, correctly managed. See, we have got the urologist. We routinely do partial nephrectomies. Some of the times we do remove some of the small tumors even in the retrieved graft, either in the cadaver. Small tumors we will remove and we do what is called sliding clip rhinorrhaphy. We take a little wider stitch and gradually adjust. The problem one should take care. We should be aware if the surgeons are inexperienced, they will make it too tight to avoid bleeding. But we have to remember we are doing this in a kidney without the blood flow. Once the blood flow comes, it can tear. So the pressure should be optimal. That sliding, normally we keep it little longer the tension can be adjusted after declamping. I hope you would understand. Once you declamp, the sudden gush of blood, the tension will increase, it can cut through. So this is the second case number 2. The case number 3 was arterial thrombus. It is very well managed. I was quite impressed. It is not like a medical college. You got such a highly trained people all the time. The 3 hours suspicion to the OT time was fantastic. I would say it's a very good time. You could retrieve it. Decision making was good, fantastically managed. The kidney got back. The only one thing I differ in that particular case, Dr. Vel Aravind, is the in situ perfusion versus ex vivo perfusion. See, you clamped the artery, clamped the vein, make a nick in the vein for the perfusion fluid to come out. You did the perfusion, the kidney in situ, right?
Yeah, correct.
Yeah. So that I would refer a little bit, because in that case you will be little bit, the ergonomics may not be that good. I don't think adding a few more 5 to 6 minutes more for a venous anastomosis second time, it is not an issue. I will always prefer take the complete. This gives few advantages. You can completely keep the kidney inside the water. The hypothermia is much better, much controlled. You can inspect with a nice loop if needed, microscope. You can see what the injury is. Correct and put it back. So this is one of the, suppose there are 2 veins. One vein is having some doubt, that we have done. Quickly one spoon clamp you can put and handle. So the other vein will be the outflow. So that is the one thing. In the last case, again, it is very unfortunate. I think this particular, I also got a similar case I have got called few times. This I remember happening long time back in one of the institution. You rightly pointed out the importance of keeping the ultrasound inside the theater and post-operative ward, and this cannot be overestimated. We sometimes we many times we call the radiologist. This is very faking. You will think that something it's looking bluish. If you switch off the light, top light, when you like to see, then that will look totally blue. If you put the light on, then you look pink. See, all are subjective.
You take photograph, it will be different.
Yeah. So our human eyes are simply perceptions. We have got optical illusions. All of us are getting aged. We have got various glasses with chromatic and all these optical illusions. So we get, let us go by the objective, this thing. Otherwise, I think the removal, and another thing is, after removing, it was put into the kidney tray, even without the ice. So that is one thing. Even you should have the grit, sustained focus, last moment till we can preserve the kidney. Suppose it is opened inside the ice, I think I would have decided to go ahead after emptying the clots. We put the capsule, few releasing stitches, few releasing incisions. Probably we could have saved the graft. I think these are the 4. But I enjoyed the discussion very well. I also learned quite a good, very interesting pictures. If I get a talk, I'll take the pictures from you. It's a fantastic. Thank you, sir, for the opportunity.
Thank you, Muruganand. Just small question actually to ask to you.
Yeah.
So you told about that arterial thrombosis where you prefer in ex vivo actually perfusion.
Yeah.
So you have declamped both, and will it be any space to again replace a kidney? So the anatomy has to be preserved, vascular anatomy has to be preserved. Already you did a venotomy, so same venotomy will be doing this.
Yeah, actually, the immediate exploration will be always the field will be very clean. The planes will be fantastic. You remove. We can inspect both the recipient artery and also donor artery. Sometimes we may have to make a small edge around 1 millimeter, both on this side to X side.
So you have a privilege of doing anastomosis with the same venotomy, actually.
Yeah.
Recipient you are putting.
Absolutely, we have done multiple times. Multiple times, if you have doubt, we see many times we have a doubt on the artery. We won't meddle around only the artery. Sometimes we just cut the one corner. It's a continuous anastomosis with the pot scissor. We can remove all the stitches. Worst case scenario, we may lose probably 1 millimeter of vein, which is very well. You can spare that. There is no problem at all.
Okay, there won't be any issue actually because it is a
no. Yeah, I think if you remember, Dr. Arvind, when you are dealing, that will be more stressful. Somebody has to keep on putting the ice. you will be handling inside your ergonomics won't.
This case, no, nephrectomy was done, no, there is a lot of space actually. I understand your point. Lot of space was there, and there are lot of residents were there inside, they're pulling that.
Okay.
And
Another
you are
one?
making another venotomy somewhere else. That also sometime if it is thin, it can also give away in the later on.
2 o'clock in the morning, half the brain is sleeping.
So that is what Murphy's law. Something can go wrong, it will go wrong at the wrong time.
Yeah, right, that's true.
Okay. So we have no other questions in the chat box, and it's all new to everyone. Actually, it's new to everyone, and it's an eye opener. And we could knew about these complications. At least we have some idea what to do.
I have 18 such scenarios I have now.
Yeah.
Oh,
We can have a series, and it's a part 1. Then we can have a part 2 later on.
These are worth even for actually a very good atlas kind of thing with a short description. You can make that excellent.
So these are all the things which actually we have no time to act. Actually, the decision has to be precise, and we should know the complications so that we can act. Medical complications, we know all the things, and we can do that. Actually, so these need a lot of guts and experience.
Another very good thing Dr. Arvind has pointed out is the surgeon will know. See, these normally the mothers will know if there is a fight between the daughter and the son-in-law, because she also went through so that the surgeon will know that I had this problem during retrieval. He will remember. So most of them, if he is honest man, he will tell that something can go wrong. So that feedback is also very important. One should not be too much defensive to produce. Anyone can do mistakes. There's nothing wrong in telling that.
That will help you make your diagnosis very quickly.
Yeah, that's true. Absolutely true.
So, with no other questions, we just come to the end of this interesting peculiar series we've been meet. And the take-home message, as we know, that first case, transaminase, you give a lot of iron pre-dialysis, and when you see a lot of increased ferritin, that is more than 1,000, and you have a transaminase like unexplained transaminase, you need to check this kind of hemochromatosis. This is very new to us, and still we have an idea that we have to search for this diagnosis if we have such a tricky situation. Second is absolutely we had a great discussion on the complication that is a part that he had as 18 cases and all, just 4 cases he has shared, and this is an eye opener, and we can have an idea whenever things go wrong in this type of scenarios, we can have some ideas. Okay, we can we can give our inputs to the surgeon, so it will be a collective effort to save the patient or kidney. And overall, it's a very good discussion and very good academic session we had for past 1.5 hours. And I must thank both the speakers who took a brilliant effort in presenting the cases, and in spite of the busy schedule, actually. And I must thank the panelists who came and gave their inputs, and of course our delegates who were there for us, and they are the backbone of our meetings and support, and the MQ team for providing the audiovisual support. And thank you one and all for the happy ending. And we look forward for the next session, which is going to be in the next month, first Saturday. We request all the institutions to come up with this presentations so that we can learn from you all, and together we can go and put a good transplant program. Thank you very much for spending time with us. Thank you. Good night.